Best mode here will be to put on NRVM. Non-rebreathing mask can give up to 50 liter oxygen, and if you are giving high flow, up to 100% oxygen. And you need to not wait too long. In 2, 3, or 5 minutes, if your patient start getting better, oxygen start getting better, then you continue. Or if you have availability of high flow nasal cannula, you can select that. If you are selecting high flow nasal cannula, you need to remember that its limitation is how to set in and how to start. You need to, it's a separate issue, but high flow nasal cannula can generate a certain level of P, up to 60 liter of oxygen you can give through that, but sometimes it generates discomfort, so gradually it has to be titrated. The third thing is non-invasive ventilation. So coming to the non-invasive ventilation, which is commonly available, if you select, what are the things which you have to keep in mind when you are selecting oxygen, NIV, HFNC? First thing, you should be knowing that this patient may get better in 24-48 hours. He will not need longer time of support. He should be alert, cooperative. He should be hemodynamically stable. He can control his airway secretion. That means he can cough and able to coordinate with ventilator, should not fight. Now, since non-invasive ventilation carry a risk of spreading the secretion, and which is a concern nowadays, so if you are dealing with COVID patient particularly, you need to have full PPE with hood and mask, everything on. Minimize your contact with the patient, put the mask from behind. Now, initially it was a strategy not to put on an IV and directly intubate this patient when they become breathless. But now people have started realizing that NIV with proning, spontaneous breathing proning patient may help. So I'm not saying totally no to NIV, but you need to be very, very careful, because if you put the patient on NIV or HFNC, there is a likely that these patients may spread lot of secretion when they cough out. You need to keep away from direct contact. You need to take full PPE precaution. You need to take due care of yourself to avoid infection. So, advantage of using non-invasive ventilation in these patients is that, or in patient who is having respiratory distress, that it gives you more confidence. Patient is alert, awake, he remains inadequately stable, and if he recover fast, his recovery is kind of faster. But you have to remember certain things. When you put somebody on NIV and they don't become comfortable, their distress worsen, the tachypnea, tachycardia worsen, they do not show the sign of recovery early, and they ventilate very fast on NIV, or they become tachypnic, that means they are not candidate for NIV, and you have to put the patient on invasive ventilation. Most important gadget to start NIV is interface. This interface can be only nasal mask, oronasal mask, or a helmet like this. And then there is a full face mask come where eyes and everything comes into contact. Depending on availability, when you put this thing, you have to make sure that your patient is comfortable, do not fight with this gadget, and he cooperates and with ventilator setting. If he doesn't cooperate, doesn't and fights when you put this on, they're likely that you will fail to implement the NIP mode. So it should be comfortable and it should be leak proof. There should not be leak. One of the biggest problem with NIV mask has been putting Ryle's tube, because if this mask is on and if you put Ryle's tube, wherever Ryle's tube will come out, it will leak. But nowadays, a mask comes with a separate hole for the Ryle's tube through which you can pass the Ryle's tube to avoid this problem. You have this kind of helmet, which is very comfortable. Here you have a port to put the Ryle's tube, and you have port to make it leak proof, because here it is completely sealed on shoulder. So nowadays, wherever available, helmet is being used with relatively good result. In India, still cost and availability of helmet is a problem. So selection of mask is the most important. Second step is how to set up an IV. Setting up an IV is also like setting up a invasive ventilation. If you have a proper machine or if you have a small uh, BiPAP machine, what you need to select is the mode. Which mode? Most of the time, when patient is in distress, preferably ST mode should be selected, where you can give the rate. You need to select the upper and lower limit or volume, like you select. Upper limit and lower limit should start from 10 and 5, and very gradually should be increased as per tolerance of the patient. You need to gradually acclimatize the patient with the flow which is coming on its face, and gradually uh, step up the mask pressure. You need to start with inspiratory. One is the rise, like it should be 10% of the inspiratory time, not more than that. Uh, you can select the inspiratory time depending upon need, which can be from 1 is to 2 ratio to 1 is to 1 ratio, depending upon the demand of the patient. You can select a 5 or 2 also in some of the good NIV machine, which can, like ventilator, which can vary from 40% to 100%, depending upon the need. But in an IV, if your patient requirement is more than 60%, then preferably they are the candidate who will get intubated very soon. So you need to be watchful for them. So setting, once you're set up, you need to, most important thing, you need to monitor that patient. Very often this is forgotten. You need to monitor three things. You need to see the monitor, you need to see the NIV screen, and you need to see the patient. Most important thing is the patient comfort. If you put somebody on NIV and patient is comfortable, is breathing, he is not tachypneic, not tachycardic, he's coordinating or not, he's triggering the ventilator NIV properly, that means he's tolerating NIV. If he's not comfortable, he's not rest, he's sweating, he's tachypneic, he's tachycardic, he's hypertensive, his saturation is not improving, that means he is not tolerating an IV and he should be put on invasive mode of ventilation. One very important concept you have to remember, that NIV has a potential to cause, initially we used to think that NIV is safe, but if patient generate high tidal volume, high minute ventilation, NIV induced lung injury is an entity. And this is one of the important factors to limit the use of NIV in ARDS patient. So we are very careful in selecting the patient, and they don't tolerate, they become tachypneic. Now we do not try too much and intubate them early. Some of the potential advantage of NIV are improved patient comfort, decreased need of sedation, decreased length of hospital stay, and some of the patients like LVF, COPD, mild hypoxemia, they have better chance of survival than invasive ventilation because they avoid the complication of invasive. But it doesn't mean that they are the mode of choice in all the patients. You have to be selective and careful in selecting the